And what can a healthcare worker know about this? Well, most of it is probably what you're already doing. I think we can build on the great success that we've had in antiretroviral treatment and rollout and apply the lessons learned from that in also treating comorbidities that are non-infectious and that may lead to increased cardiovascular risk. So we know that controlling HIV may decrease HIV-related inflammation and could ameliorate the CVD risk, even though it would not eliminate it. Starting people on treatment earlier and at higher CD4 cell counts may help. And that we should think about patient-specific cardiovascular risk when selecting antiretrovirals and avoiding antiretrovirals, for instance, that may increase cholesterol levels or increase dyslipidemia in people who already have baseline dyslipidemia. That we have to think about their HIV when we're assessing their cardiovascular risk, and that we need to communicate that risk to our patients better because they may not be thinking about it. A lot of them are relatively young people who are focused only on their HIV care and the infectious complications and not really even thinking about heart disease risk. We just had a new guidelines for hypertension treatment, which are going to send all of us into a tizzy. But the American Heart Association has redefined hypertension as any blood pressure of greater than 130/80, as opposed to what we used to use as 140/90. And so we now have stage 1 and stage 2 hypertension. So the 140/90 is cut off for stage 2, but stage 1 is anything between 130 to 139 systolic and 80 to 89 diastolic. And the other cardiovascular risk factors that we have to think about and that the AHA is encouraging us to think about when we try to control patients' blood pressure is what is modifiable and what is not. So there are some things that we can't fix. We can't fix their family history. We can't change the fact that they have HIV. We can control the HIV, but we can't change that fact. We can't change their age. We can't change their gender. I would argue that we should be able to try to help people where there's psychosocial stress, but we can't prescribe them a medication for that. But we can work on smoking cessation. We can treat their diabetes. We can control their lipids. We can try to help people to lose weight, try to help them to increase physical activity, and address diet. This is a summary of the recommendations that the AHA made in 2013 for to reduce cardiovascular risk. This is all linked to the pooled cohort equation. If you have clinical atherosclerosis, yes, you go on a statin. And the subsequent slide will look at the definitions of high versus moderate intensity statin. If you don't have active known heart disease, but you have an LDL cholesterol of 190 or higher, you go on a high intensity statin. If you don't have heart disease and you don't have a high cholesterol, but you have diabetes, you are selected for either moderate or high intensity statin. If the answer to all of those is no, then you estimate the 10-year risk using the pooled cohort equation. And if it is greater than 7.5, you're recommended you go on a statin. 5% to 7.5, consideration should be given to a moderate intensity statin if there's not any contraindication or if there are not other things you might want to address. If people fall outside of this box, then you have a discussion with them about non-pharmacological interventions before going to statin treatment. So what benefit could they get from a statin? What benefit could they get from increasing physical activity, paying attention to heart-healthy diet, controlling blood pressure, controlling their, working on smoking cessation and stopping cigarette smoking. And with a lot of my patients, we kind of go this route first, if they're greater than 7.5, then we go to statin. If they fall under kind of none of the above, then we have a discussion about heart-healthy lifestyle and other non-pharmacological activities, and again, go back up here, reevaluate, and then make the decision again in about 6 months. This table addresses high, moderate, and low-intensity statin therapy. Basically, high-intensity statin therapy, people with known heart disease, people with diabetes, would be atorvastatin 40 or 80 milligrams. More data available on 80 than on 40, and rosuvastatin 20 milligrams. And we do have to think about drug interactions with our antiretrovirals. So people on cobicistat or ritonavir should get lower doses of atorvastatin. And really, we've been starting them at 10 and not going above 20. And we use rosuvastatin very cautiously, and I don't really actually use a lot of it. But with all of the statins, we have to look at drug interactions. We would not use lovastatin at all with any of it, or simvastatin with any of our antiretrovirals.